Hello, and welcome to the Center for Health Design's Evidence-Based Design Journal Club. Thanks for joining us. I'm Alan Card, a research associate with the Center for Health Design, and I'll be your host for today's session. For those of you who are currently designing a behavioral health facility, join us in Arlington on September 26th for an interactive collaborative problem-solving workshop intended to enable design professionals to employ physical design strategies and methodologies that support improved care for behavioral health. Register by August 31st, that's tomorrow, and save. Before we begin, I'd like to thank the Herd Journal for providing free access to the articles we typically review. If you have not already done so, we recommend subscribing to Herd. There's a discount code for attendees to receive 10% off the subscription. The purpose of the Evidence-Based Design Journal Club is to engage the healthcare design community in dialogue regarding important research to help us better understand the links between the built environment and health-related outcomes and to apply that in the real world. I'm now excited to introduce you to the authors of the article we'll be discussing today, Darcy Copeland and Sam Burnett. Darcy Copeland is an assistant professor of nursing at the University of North Colorado and a nurse scientist at St. Anthony's Hospital in Lakewood, Colorado. Her clinical background is in mental health and forensic nursing. She has a master's degree in forensic nursing from Fitchburg State University in Massachusetts and a PhD in nursing from UCLA. She's actively engaged in research and evidence-based practice projects, facilitates an interdisciplinary evidence-based practice fellowship program at St. Anthony Hospital, and has experience conducting both quantitative and qualitative research. Her most current research has looked at the relationships between healthcare provider perceptions of safety, exposure to violence and moral distress, burnout, and secondary traumatic stress. Sam Burnett serves as a Sam Burnett serves as the principal in charge of the design for St. Anthony's Hospital, the project highlighted in this presentation. Sam has 34 years of experience at ESA in land planning, master plan design, and design of new hospitals, hospital expansions and renovations, medical office buildings, outpatient surgery centers, cancer treatment, and nursing assisted living facilities across the country. As an astute speaker, researcher, and writer, he often tackles current pressing healthcare issues to help educate healthcare designers. Of these, he is a strong advocate of patient safety. He sees hospital-acquired infections as an ongoing issue. He was invited to author Infection Control, The Good Fight, an in-focus article that was published in the October 2016 Journal of Healthcare Design magazine. He was a guest speaker in 2016 at Texas A&M's Healthcare Design Lecture Series and in a presentation entitled Safe Room 101, Elevating Your Patient Safety Vocabulary. This spring, he presented Evidence-Based Design, Design Factors Impacting Outcomes to the 2017 HCA Spring Training Conference in Nashville. He currently sits on the editorial advisory board of Healthcare Design magazine. Thank you both for joining us today.
Thank you.
As I mentioned, we're hosting this event to identify the everyday practical applications of research findings in a published article. Today's featured article, Effects of Unit Design on Acute Care Nurses' Walking Distances, Energy Expenditure, and Job Satisfaction, a pre-post relocation study from the Health Environments Research and Design Journal. On today's call, we'll have an active discussion about different key factors in your study. And now, if you would, please take it away.
Thank you, Alan. Good afternoon, everyone. St. Anthony Hospital is a replacement facility, and those of you in the design business know that the replacement hospitals are far and few between the renovations and multiple small additions that we do to our projects. This facility had endured decades of growth and expansion and modifications and essentially outlived its life and its functionality on its current site, and it provided a phenomenal opportunity to look at the existing conditions that were going to be researched and look at a clean slate with a new facility that took those ideas and opportunities in a brand new building about 8 miles away from the current site. It also was an opportunity for us and the project management team to do a worldwide tour across the country and tour 10 facilities that we deemed best practices that were taking place at the time. We learned a lot from those facilities, not only what they did right, but things they would have done differently. We had goals that we established. We knew that we couldn't research everything possible, so we did focus the research on the units, on the bed units themselves. The specific goals of the research were to look at decreased nursing workload, bringing caregivers closer to the patients, increase caregiver time available to the patients, reduce falls of patients, and reduce walking distance for the nurses per shift. And these 5 goals are not only individually measured, but an opportunity to have a synergy within themselves. For example, increasing caregiver time to the patients would inherently support the goal of reducing falls. The idea was to make the unit itself very supportive of allowing the nurses to do their work and not spend excessive time walking and searching for supplies and making long trips to central support centers, clean meds, and so on. I want to spend a minute on this existing hospital, the former plan, which is very common in the U.S. The good racetrack design was somewhat ahead of its time because it did bring support to the middle of the nursing unit. These older models, however, were very dated, and the term we use, opaque. There's very few passable, visible passages through the unit. You can see the light blue central nurse station in the middle, and the 2 corridors at each end of the unit were the only real visually accessible views across the support core itself. So that was a problem from a visibility, and the nursing management continued to tell us we need to be able to see and find each other throughout our shift. We need to know what's going on in the unit and not have the building itself be a visual obstacle to that. The green areas in this unit were good, but there are not enough of them, and those are some of the supply-intensive and travel-intensive spaces that were duplicated in 2 locations within the unit. Still, with that said, there were a lot of opportunities with this plan to improve. So I'm moving forward to the replacement facility, and what you'll see in the replacement facility are some of those issues are already addressed. And although it is a very simple rectangular plan, we have immediately grasped the opportunity to go with deeper rooms and outboard toilets that shorten the corridor from the wider rooms with toilets in the middle that you saw in the previous plan. That also enhances visibility along the corridor by getting those toilets off the corridor walls. Second thing to note is that the original building that we moved away from, the unit that we studied the most, was a 28-bed unit that included a mix of semi-private rooms and 22 private rooms. We're going to a 36-bed facility with all private beds, so that inherently would add some length to the corridor. But by shortening the rooms, 2 rooms per 28-foot column grid, we were able to manage that with just a modest length addition to the previous plan. 2 things I want you to note in the plan are the red arrows, which show the opportunities for visibility and sight lines for the staff to see through the unit, not just across corridors, but through certain rooms, including the nurse work centers themselves, and multiple locations for staff passage throughout the support. And lastly, the duplication of the support is very carefully studied to get meds, clean supplies, soil, linen, and trash removal, and other small staff support spaces such as nourishment duplicated on each side of the 2 18-bed rooms.
All right, so the research itself, as you can see, the purpose of the study was to determine what differences, if any, existed in the number of steps taken and the amount of energy nurses were expending, acute care nurses in particular, when their work environment moved from our old hospital that had these centralized nurses stations to a hospital with decentralized nurses stations. So additional goals of our study became to determine design features that nurses perceived as either contributing to or deterring from their work activities, to determine what changes, if any, occurred in reported job satisfaction when they moved from one environment to another, and then also to monitor patient falls. So we used a pre-post quasi-experimental design We had nurses who were participating complete an open-ended questionnaire and record pedometer data for every shift they worked for a 3-month time period. So we collected our pre-relocation data for a period of 3 months. The hospital moved, and then we waited 9 months to begin post-relocation data collection. We wanted all of our staff to have those 9 months to literally just get used to the new layout of the building in general, to figure out their way from point A to point B in general. So we wanted everybody to be acclimated before we started collecting data again, and then once those 9 months had passed, we collected the same data for another 3-month period. So our participants, participation was open to all full and part-time day, night shift RNs who were permanently assigned to one of our 3 acute care units in either hospital. So these 3 acute care units were and currently are structured. One is an orthopedic neurological unit, one is a medical surgical cardiac unit, and the third is a medical surgical trauma oncology unit. And the nurses were invited to participate through an organizational email sent to them. All of the data collection procedures and instruments were identical pre- and post-relocation. I am the principal investigator. As I met with each participant to go through their informed consent, while they were reading their informed consent and filling out their open-ended questionnaire, we provided pedometers to all participants, and I programmed each pedometer myself. And I'll get to the open-ended questions we asked them were the following 5 questions. Can you please describe aspects of your physical work environment that help you do your job and get your work done? Please describe aspects of your physical work environment that make doing your job and getting work done difficult. Please describe any other aspects of your physical work environment that you like or dislike. Please describe any aspects of your job that satisfy you, and describe any aspects of your job that dissatisfy you. We wanted to be able to weed out, those last few questions were intended to weed out general satisfaction and dissatisfaction from satisfaction and dissatisfaction related to the characteristics of the physical work environment. And then the final question they were asked as part of the questionnaire was to please rate your job satisfaction on a scale of 1 to 10. Participants were instructed to wear their pedometer during every shift they worked for a 3-month data collection period. At the end of each shift worked, they were asked, I provided them with a record-keeping log. They were asked to record the following. Was it a day shift or a night shift? All of our nurses are staffed on 12-hour shifts, so it's either a day shift or a night shift. The number of hours they actually worked, the number of patients who were assigned to their care during that shift, and then to record from the pedometer the number of steps they had taken and the number of kilocalories they expended during that shift. Our patient fall data for the same 3-month pre-relocation and 3-month post-relocation data collection periods were extracted from occurrence reports. I used SPSS version 20 to conduct data analysis, and the statistical tests I ran were chi-square test of independence, independent sample t-tests, and ANOVAs. And then we just used content analysis to analyze responses to those 5 open-ended questions. So what did we find? We had 26 nurses participate pre-relocation, 35 nurses participate post-relocation. We did have more day shift nurses than night shift nurses participate. And we'll see on the next slide the actual number of shifts reported. Not surprisingly, the majority of our participants were female. They were most of them in their mid-30s. As I already mentioned, most of them worked a day shift. This was a group of relatively experienced nurses in general. You could see the mean number of years as a nurse was 6 pre-relocation and 8 post-relocation. And then the amount of time they had been at our hospital, a mean of 4 years and a mean of, again, roughly 4 years. So pre-relocation, these participants logged 525 shifts. Post-relocation, they logged 1,009 shifts. There was a significant increase in the mean hours worked per shift post-relocation and a significant decrease in the number of patients they were taking care of per shift post-relocation. More interesting to you is probably these next couple data points. Post-relocation, there was a significant reduction in mean steps taken per shift, and there was a significant reduction in mean kilocalories burned per shift. We saw no significant change in reported job satisfaction. Pre-relocation, during the 3-month data collection period, those 3 acute care units reported 51 patient falls. Post-relocation, during the 3-month period, there were 23 patient falls, which translates into a 55% reduction in patient falls. You may or may not see in literature, the typical way that fall data is reported is falls per 1,000 patient days. I had to rely on the data that was made available to me to calculate our patient falls, so I can only report literal numbers of patient falls. It is kind of important to emphasize that, as Sam mentioned, the number of beds increased post-relocation. So pre-relocation, there were 28 beds per unit, 51 patient falls. Post-relocation, we had 36 beds per unit, 23 patient falls. So clinically, that is an important finding. So as far as the more kind of qualitative information, I've tried to highlight for you with respect to aspects of the physical environment that help nurses do their jobs, the aspects related to kind of physical design as opposed to equipment they have available to them. So things that help nurses do their jobs, you can see the first 2 points on the pre-relocation and post-relocation columns are the nurses' stations. So pre-relocation, they thought the centralized nurses' station helped them do their jobs. Post-relocation, they thought that multiple nurses' stations helped them do their jobs. That's the nature of data collection. It is what it is. You can see post-relocation, the tube system having multiple nutrition rooms. I continue to hear about the effect of multiple nutrition rooms to this day, and the amount of lifts that were placed in patient rooms helped them do their jobs. Things that came up both pre- and post-relocation were having supplies available at both ends of the hall, having multiple medication rooms, and the floor layout in general. Then things that make it difficult for nurses to do their jobs. As you can see, pre-relocation, not having lifts, not having counter space, double rooms. There was only 1 staff bathroom. So some of those problems were fixed with post-relocation. They felt that the supply room was too far away. Nurse servers were not installed. Dirty utility is too far away. And the layout, teamwork, suffering comments were all related to the long unit, probably because things are decentralized. Nurses are staffed either on the north end or the south end of the unit with their patients, and there's really not a lot of reason to cross over to the other side. So the feedback that we got is that they don't have as much of a sense of when their coworkers on the other end of the hall are specifically struggling with their workload. Long travel distances and crowded nurses' stations popped up both pre and post. Limitations of this particular study, it was a single study with a relatively small sample size, and we did not incorporate any observations, so whether or not actual time spent with patients changed, we don't know. Participation was also limited to RNs. We did not include any other members of the care team, including patient care assistants or CNAs. And we also didn't track any operational changes that took place. So any changes that might happen as far as nurse-to-nurse reporting or the way staff huddles took place, we didn't track any of those operational changes. So, conclusions of the study, we did see again a statistically significant reduction in steps taken and energy expenditure. No statistically significant change in job satisfaction. We did see a reduction in the reported dissatisfiers related to the physical environment. And again, we saw a 55% reduction in raw numbers of patient falls. So, Sam.
Thank you, Darcy. I'm going to present some plans and graphics to give you an idea of some of the exact implementations that we selected to support the research and with all hopes of improving some of the preconditions cited in the survey. In the plan, you'll see the demarcations with the S for steps. That involves research on travel for the nurses, and patient falls will be marked by F throughout some of these shots. Specific to the steps, we wanted to standardize the patient rooms. These are not same-handed, but they are left and right, so there's two essential rooms with just mirror imaged. So the staff are not having to acclimate and get oriented to multiple room configurations. The simplicity of that and being able to find supplies, restock, have what you need when you need it is supported by that. Decentralized support was very important, and no plan's going to allow you to duplicate everything on each end of the unit, but we opted through multiple interviews with the staff to put nourishment, clean storage, med rooms, trash removal system through a pneumatic tube system. This particular system was called TransVac, and it was a very popular system that takes trash away in large pneumatic tube systems, and soil in it as well. Darcy mentioned staff toilets. She said the old unit had one. And to my designer friends on this call, those of you who want to endear yourself to your user groups and your clients, provide more than one staff toilet in these nursing units, and you will be forever appreciated as the architect of the year. And that's also one of the green areas in each wing, again, because it's travel intensive and intended to help the staff minimize going to one central location. Specific to steps, again, this is the Central Communication Center, and we opted to not tag this as a nurse station because the nurse work centers are really in the two wings. This is a command center for the unit secretary. The charge nurse may choose to work out of this zone. Any of the nurses and technical and support staff can work out of this zone. It's intended to be a communications hub and give the staff the opportunity to meet and huddle in the center at the appropriate times. You'll note it's a wayfinding node as well with the large bulkhead feature in the ceiling to break up that long corridor and give you a point of reference from each end of the unit looking down the corridor. This is one of the
Sam, hang on, Sam, can you, going back to that picture, one thing I wanted to point out, if you can't see it in this picture, but off to the right, what would be the right of this picture, are the patient elevators. There's a patient waiting room and visitor elevator, visitor waiting room, and visitor bathroom. And as visitors exit the elevator, they come through a door, and that is the first thing they see is somebody sitting at that desk, either a clerk, a registration clerk, or a unit clerk. That's the first thing they see. As an employee of the facility, it's extremely helpful to have that be the first thing people see. So they have somebody to ask their questions to immediately.
Yeah, thank you, Darcy. That's a good point. I'll go past this one and go to the next shot. This is one of the two decentralized nurse work centers in each of the two 18-bed zones. We've located these so that they are geographically in the center of the two 18-bed zones they support, and the farthest bedroom door from the center of the station is in the 48 to 50 foot range. The closest one is about 10 feet just immediately across the station. So it was as close to the center line of each of the 18-bed zones as we could get it. You'll see the visibility. The picture helps tell the story better than the plan. This is looking across the support core. You put a bulkhead in just to define the space off of the corridor, but you can see through zone itself. We did not put a lot of wall cabinetry and other features in the middle of this unit for that reason. The decentralized work center also has some off-stage space. If you'll look at the far left, you'll see the lady in the area where the windows are. They are just off-center from the main station where they can work near the station, have visibility of what's happening in the corridor, but not be right on the front lines of the activity. The third work center, from the plan, you saw the small blue dots that represented the work alcoves between pairs of rooms. And those of you in the design industry are doing these a lot. We saw a lot of these on the tours to give the staff and nurses a place to chart, to confer with a coworker close to a room as they're rounding between patient care, as opposed to having to walk back to the center for every task and every detail. And again, the visibility into the room, a lot of effort was put into this. We did the double door configuration with a 4-foot and a 2-foot side leaf. So you get an effective 5-foot, 10-inch opening with the doors open for those transports and for getting in and out to that patient during, maybe large equipment or that occasional crash situation where you need quick access to the patient as well as visible access. And then not on the slide, but we had to manage the need of the staff to see the patient with the patient family's desire to have privacy. So for that reason, there's integral blinds in the glass and any of the glazing that's open, visibly open to the units. This shot shows a lot of the features implemented that we've talked about, some of them already, but particularly, we'll start on the left. Decluttering the room is so important, that the room is not full of mobile equipment and poorly planned furniture and supplies where the staff don't have a place to keep their supplies. And this photograph tells a story. There's a very clear path of travel between the corridor, the bed and the toilet. There's a clear staff work zone and a family zone that do not click with each other as well. We wanted to avoid trip hazards, and one of the things identified during the relocation study is the very difficult flooring transitions between the room itself and the bathroom with the flooring material change. There's a transition strip, if you will, and between the shower and the rest of the restroom typically is going to be a curb or a very awkward short step to step over into the shower. We've eliminated both of those in this plan with depressed floor slabs and seamless transition in those flooring to shower changes. We also employed added grab bars, and if you'll notice on the journey between the bed and the bathroom, for that leap of faith between the bed and the bathroom, when those patients do try to make that journey unassisted, there's immediate grab bar support on the outer walls to help them literally cruise to the restroom fixtures from the bed. And then lastly, a real commitment to put in ceiling lifts. Not just a few, which sometimes gets put in and you don't get the training and they don't get used. There was a commitment to put in lifts in every room, although they could not all be funded in the initial opening. The steel or the red iron in the ceilings was funded for every room so that they can fund ceiling lifts in every room over the next few capital improvement years to get those funded is added. So the design implications. In the post-occupancy, Misty and I spent a lot of time with staff on the frontline units and spent time with them, actually shadowing them on the units. And some aha moments that we got in talking with the staff. And one of the ones that was very memorable was the fact that the Pyxis units, in this case, the dispensing systems for the 2 med rooms, did not have redundant med supplies for patients in the 2 zones. They were staffed for patients in beds through 118, and again for patients 19 through 36. So for those nurses who had patients in that crossover zone in the high teens and low 20s, they were having to travel to both med stations. That was a real aha moment for us. And you would probably run into that at most facilities unless you purposely involve the pharmacy staff in how you stock these systems and how you assign nurses to patient rooms. And then from the feedback in the survey, we heard several comments about the nurses had the perception that they did not have the ability to huddle and communicate because we had broken up that one big central station into multiple stations. And although the central communication center is there, if their work areas are in one of the other two stations, they did feel isolated from each other in some of the comments that we heard. So in hindsight, I think that is a very key topic to discuss in your user group meetings. Be sure that base is covered without exacerbating the whole travel distance goal that was in this study. In final thoughts, we do know from the pre and post design that unit design does impact the amount of walking and energy expended, as the research showed, and we were proud to see that. Patient safety is and always will be paramount, and unit design can affect that positively. The phenomenal reduction in falls that was noted by Darcy, and the nurses' ability to do their jobs. You know, there were a lot of comments from both pre and post about how that was impacted in the pre and post construction. Darcy?
So other kind of discussion points, as Sam and I have both already kind of indicated, the idea of culture is important. And as Sam has said, what worked for us in Lakewood, Colorado might or might not work in other parts of the country. So taking the culture of the units themselves into consideration, with things like communication, for example, in particular. How do staff members on these units prefer to communicate with one another? How do they actually communicate with one another in things like huddles and whatnot? Definitely involving frontline nurses and other staff members in the design plans. Where do they want things? And again, I'll go back to multiple nutrition stations. That the nurses absolutely positively love that, and they love that they're open to visitors. So no longer do nurses kind of have to feel like waitresses, because visitors can go in and out of the nutrition rooms on their own. So involve frontline nurses in decisions like that. And then I cannot say enough how important in this particular study the partnership between Sam's team and myself was. So I'm a hospital-based researcher, and fortunately Sam and his team came to me early enough that we had adequate time to kind of design this study to determine what were important outcomes to measure, how we would measure those in order for me to get the research through the IRB process in time to collect pre-relocation data. Had he come to me later in the process or after the fact, that pre-relocation data collection would not have been possible. So that was a key to the success of this particular research project. I think that's all we got.
Fantastic. Thank you. Before we get to the Q&A section, I'd like to make a couple of quick announcements. This event is brought to you by the Center for Health Design. Thanks again to the Herd Journal for providing free access to the articles we typically review, and special thanks to today's sponsor, Steelcase Health. And now, the exciting part, your turn to ask questions of the authors. Please feel free to type in any questions you may have, and we'll try to answer them. We already have quite a few lined up, and we will get right to them. I'll leave this information up about the CEUs so people can track that down while we're talking. We'll start with a real quick and easy one. Does the patient have an external view from the bed? It was a little hard to tell from the angle of the picture.
Yes, Darcy, I'll answer that one. Yes, we spent a lot of time deciding whether to put the toilet and the bed on the same wall or actually put the bed opposite of the toilet. And in other facilities, it's gone the other way. But this team, particularly the nursing champions, as they were called, were very supportive of safety over everything else. And so that put a little bit of a challenge on the design team because we didn't want to totally cut off views. And so we looked at visual sight lines, things like the angle of how we clipped the bathroom door, how shallow or how deep the family seating alcove was, and even how we situated the bed head wall, and we found that common ground where there was a cone of view, although it wasn't a 180-degree view. There was a nice cone of view from the bed through that family alcove to nature and the trees and natural light and so on.
Fantastic. And that sort of relates to this next question, what you're talking about there with the safety and the angles, was there consideration or planning for directional lifts that go continuously to the bathroom fixtures to reduce falls for patients?
It was discussed, Alan, and thank you for that question. The ones that will actually go in two directions or take the patient all the way to the restroom was opted by the owner and the frontline users not to employ those, but to help with the day-to-day transfers. And they opted, in those cases where those patients were in such morbid obesity or in such bad shape to go to the restroom, they preferred to take care of that at bedside. That was a nursing decision.
And in terms of falls, obviously you weren't doing an epidemiological study on it, but do you think that some of the other questions that people were raising were, could the lifts have played a role? Could lighting and perhaps lower glare floor tiles, if you move to those, have played a role? Could, I believe somebody just asked about organizational changes have played a role. Could you talk about some of the influences other than just the layout that you think may have impacted falls, and as well what you know about how the falls were measured? For instance, was it just through routine incident reports?
Darcy, you want to take this one?
The fall data that was made available to me was strictly through incident reports, and all healthcare providers are required to complete an incident report on any patient fall. There are definitely limitations with respect to what I was provided. So those numbers are, again, just strict numbers of patient falls that occurred on the unit. Whether that fall was in the bathroom, in the bedroom, in the hallway, I wasn't provided with that information. We do know in general, literature tells us that the majority of patient falls do occur in and around the bathroom. I can tell you anecdotally that is true of our facility. With respect, there was a question about organizational changes. So we, again, as the research side of it, we didn't keep track of whether or not there was, for example, a falls initiative in that 9-month period. I'm not sure. We didn't track that. We saw, again, I'm limited in the data that I could report to you all. We saw a reduction in falls. The reasons, though, that we saw those, hopefully many of them were related to physical design. Beyond that, I don't have information. I don't know if that really answers that question, but...
Well, at least tells us what we know. And related to that, which may, again, be beyond the scope of what you guys have access to, you increased the number of beds and slightly, if I remember correctly, decreased the number of patients per nurse. So I assume you increased staffing to some degree. Could you say a little bit about that? Was it a change in the staffing model or just hiring new nurses to meet the number of beds or anything like that?
So there might have been some confusion then with the number of patients taken care of. I think that might be what you're referring to. The staffing matrix did not change. So the hospital staffs on a census basis, and that is still the case. It was before we moved, and it is after we moved. So staffing is based strictly on census. So if there are 36 patients on the unit, there are X number of nurses. If there are 28 patients on the unit, there are X number of nurses. But the staffing ratio did not change. It just so happened, it was kind of an unintended finding that the number of patients that nurses were taking care of pre and post changed. But that it was not due to changes in staffing, either matrix or otherwise.
Okay. That one we already covered. Work centers, this is an interesting question. Work centers are open to enhanced visibility, but did clutter on the flat surfaces become an issue? I know they would for me. It's my level of organization.
Clutter, like clutter in the hallways?
Clutter on the desks, I believe, was the idea, the flat surfaces.
Not on those, the workstations that are every other room. There is no because they're not dedicated to any one person or any one team of people. It's more people kind of coming and going. So every now and then, maybe a social worker will leave a clipboard on there while they go into a patient's room and then come back out and retrieve it. But they are not used to store any type of materials. All that's there is a computer, a screen, and a keyboard. So there's no clutter on them.
There are supplies above, but in all intentions of keeping that countertop free when it's not in use.
Fantastic. What discussions were involved for using a mirrored patient room layout versus same-handed?
That is a tremendous question, and it's a question Alan will continue to debate on every project. The bottom line was cost. The duplicity and the back-to-back economies of the med gases, of the plumbing, and the stacked restrooms, and the ability with the outboard toilets to get the massing with the glazing and some patterning on the exterior. Although the architecture was not driving that decision, it was supported by that decision. And the owner and the frontline users made arguments the other direction, that there are times when having an opposite side is actually helpful, depending on how they want to examine the patient. So from a pure cost standpoint, if I had to give a one-word answer, it was cost.
Fair enough. During the design stage, were the staff aware that reducing steps by decentralizing care desks might compromise the team's ability to collaborate? Was this something that they thought through beforehand, or something that they just discovered after the build and the move?
Darcy, I'll hit this from the front end. You may have some comments from what you saw in the surveys. On the front end, it did get discussed, and it's a cultural change for that staff when they've been living in one central station for years and years in some cases. So for that reason, we opted not to totally eliminate a central station. We just did not call it a nurse station. If you remember the floor plan I showed a little bit earlier, there are supplies and equipment to run a nurse station out of that central unit, possibly for the third shift. That late night shift may want to run totally out of that unit. It also gives them a place to huddle. And so when Misty and I did the post-occupancy, we asked about that question specifically, and the answer we got was the staff are free to work out of whichever station they choose to. They're not mandated to work out of the two 18-bed zones, and particularly those nurses who have patients in that middle zone, just planned south of the middle unit, and work out of that station and have touchdown work task at the other two. So from a design standpoint, that was the discussion we had both pre and post occupancy. Darcy, you may have some insight on what you saw in the surveys.
No, not beyond.
Were there any things that did come as surprises to you, unforeseen impacts of the design?
Some of those aha moments that I mentioned earlier, I think the med room was big, and I would not recommend going back to one central medication room, because that's a long distance to those most remote beds at the end of the corridors. But it is very important to be sure that we're not complicating the inventory and how these Pyxis or other med stations are stocked, taking care of those patients in those crossover zones where nurses may have patients that are in that middle, that 50-yard line or that middle zone, if you will. That was a big aha. The other item that we thought was interesting was some of the nurses that we saw on the unit spent all of their time in the satellite stations or the two decentralized stations, and some preferred being very social and being in that middle station, even though they had more travel involved in the care of their patients.
And somebody asked a question that reminds me of, and it was, we do always talk about the culture change that will be necessary, specifically, as you found out in your results, the change of talking with your coworkers that occurs when moving from central nursing station to a decentralized plan. How do you approach this prior to the physical move? So you did say that this was something that they had thought through, and that it was going to be a bit of a culture change. Was there anything that they did to try to make this work better despite that change beforehand, or was it more of a settling out process afterward?
Yes, and Alan, this is a phenomenal topic, and it should and continue to be a topic as you're planning future units. I can't say enough positive about the nursing leadership on this project, that they embraced this process to help reduce steps and fatigue and wasted time walking and all the negatives that come with one large central station and very remote patients at the end of the units. And so not only were they our frontline go-to staff on the design reviews, they took these ideas back to their coworkers, and they pinned plans on the staff lounges, on the walls in the staff lounges, and talked about this during their weekly project and team coordination meetings. So it wasn't just a small sampling of the nurses that had knowledge and involvement of this planning. It was one of the best examples I've seen of nurses taking the message back to their staff and their teams.
And I can throw in the comments we got were very much about real concern about their colleagues. We weren't hearing comments that, I don't have enough time to socialize, or I don't have the opportunity to kind of socialize with the people I'm working with. It was very specific to the idea of not knowing if their coworkers were struggling. So, I mean, as in future, as you are talking to people, finding out how that kind of communication takes place on a unit. Like if there is a staff member who's struggling with workload, how is that message spread across the unit so people can come to that person's aid? I mean, it was very specific about not knowing when people need help. Not strict socialization, I would say.
Mm-hmm.
Great, and that leads naturally right into another one of the questions that was submitted, which is, were there any other technological changes that you either considered or put in place to try to improve situational awareness in addition to the actual layout changes?
Yeah, so I can talk to some of the technology. So at each of the two sort of decentralized stations, there are telemetry monitors for those specific 18 beds versus those specific 18 beds. So each of the decentralized sort of stations have telemetry monitors for any patients being monitored. The central station has all of the patients who are on a telemetry monitor, the screens available there. The decentralized stations, I mean, they're really fully functional. There are printers, fax machines, phones, desktop computers, these telemetry monitors. They're really very functional, independent units.
And An interesting question that actually jumped out at me too was in the seamless flooring solution from patient room to toilet to shower, what are the actual flooring materials and how have you maintained an adequate coefficient of friction to ensure that any water on the floor doesn't increase the risk of falls?
That is a very good technical question. The generation at this hospital at the time was a satin finish type tile that was not a slick tile. It had the slip resistant coefficient to it that allowed us to, we actually depressed the floor slab to get the tile set so that it was flush with the patient room. And likewise for the flow to the shower. So there's a very sophisticated series of almost invisible drainage lines that allows the shower water to flow to the shower and an overflow shower drain as well. And that coefficient is very important. You wouldn't use the slick subway tile, for example. But now in today's generation, just to give a complete answer, we are having a lot of success with resonance flooring. I won't name brand names, but there are several out there at different price ranges, and that price is coming down. And that's a poured flooring that allows you to turn it up and get a seamless cove on the wall as well to help with resistance, mold and algae and so on. It helps with the EVS staff and their cleaning of those rooms. So in today's generation of patient rooms, I'm a big fan of the resonance flooring as an option. And then the third piece of that is, the depressed floor slab, we hope, is a thing of the past. And anyone doing renovations of existing buildings, it's very difficult, if not impossible, to do that after the fact. There are some very innovative products out there with showers, pre-manufactured or prefab showers, that have such a thin profile that they can be put on top of a slab, and you can feather up the flooring product, like the resonance flooring, up to that edge with a trench drain, and it eliminates that very complex and very cumbersome stepped or depressed structural floor system that is very costly in the structure itself.
And that leads into another question that I really want to make sure we get to before we finish, which is, as you mentioned, complete rebuilds, new builds are few and far between. What lessons do you guys think that people who are just doing a refurbishment project could take away from this and use for their work?
RC, would you like me to take the first stab at that?
Yep.
Okay. Well, Alan, you're exactly right. Most of our projects are renovations or renovations and additions. There's too many projects out there with a lot of sunk costs that are very difficult to just totally walk away from those campuses and build new. So a building has to go through quite the functional obsolescence survey before owners can really justify rebuilding a brand new facility. So in those renovations, I think the takeaways are you're as flexible as your structural grid will allow you to be. We've done some very aggressive interior demolitions and put back very, very modernized units when the column grid allows it, and allows you to get, for example, 2 patient rooms per column bay by today's FGI guideline or today's standards of minimum room clearances. And sometimes you just can't go in and surgically save half your walls and do it the right way. And it actually can cost more in the long run to try to keep part of your electrical and plumbing systems intact. So I would look at the plan as a fresh slate when you can. Look what the structural system will allow you to do. And you can decentralize these stations when the plan allows it, particularly if it's a racetrack plan. But if it's a very we'll call it a very lean design, double-loaded corridor system, you have to make some concessions and probably give up some patient rooms in the middle to get that support, or even in 2 zones, get that support decentralized so you don't have those big islands of one-of-a-kind support that are 100 feet or more away from the furthest patient room.
I mean, from my perspective, I can't speak to design in any way, but I will go back again to that idea of culture. In any of our work environments, we can point out things that do work for us and things that don't work for us. So as Sam's team did, the idea of literally talking to the people who are walking that space every single day for 12 hours, they know what works and what doesn't. They know what they'd like to see change and what they would like to see not changed. That was a big take-home for me, I would think, for any project, whether it's new or just refurbishing existing spaces.
That's right. I mean, this is about the people. It's about the end users, your staff, the patients, and their families. And that willingness to try something different from what they've lived in for 10 or 15 years is a big shift of culture. But if they will embrace that there's a lot of opportunities to improve the things that we researched in this project, and healthcare infections and falls, and improve staff retention. There's so many opportunities when your end users are willing to embrace those changes.
Another great question that I almost missed is, in looking at your data, you had a 3.5% decrease in walking distances. Have you quantified and identified where the nurses were walking to that limited the improvement? For instance, were they having to go to 2 different med rooms, et cetera?
So as I mentioned, I was not able to incorporate any observation into data collection. So I can give you hypotheses, but I couldn't give you any. We didn't collect that. I mean, as I've kind of mentioned, there's no need for people to walk very far anymore. Everything they need is in a much smaller space than it was in the past.
Okay.
So I don't have that data.
Fair enough. And can you direct to some sources for these innovative flooring and shower products? I know you don't want to promote, but apparently they're looking for a little bit more direction on where to find more information.
Sure. Yes, we'll start with the shower, if that's okay to give a plug for these companies. Vendura is one that comes to mind. They do the prefab units with a very thin profile that tapers out to a trench drain as it meets the flooring of the bathroom. And those can literally be set on an existing slab. And you can build your bathroom flooring up and down to that trench drain as you need to drain the overspray or the water as the patient exits the shower, so that it's not seeping out into the patient room itself. Comfort Design is another one that we've used in other facilities. Both of those have some good stock products, and I know Vendura, through experience, will customize a shower size for you. If you're doing 10 or more showers, they probably wouldn't do it for 1 or 2 showers. But if there's a little bit of quantity, they're very receptive to customizing those shapes and sizes for you. On the flooring, there are, if you will just Google resinous flooring, you should see half a dozen products that will pop up. On it's a very it has kind of an epoxy type finish to it, and you can specify the grit and the slip resistant coefficient so that it's not a slick flooring. The sweet spot in resistance is somewhere between tolerable sandpaper and a satin finish, so that it's not rough to the feet, but when it's wet, it's not you're not going to slip on it like you would on a slick tile floor. ResTech is one that comes to mind, and there are others out there, but you'll see a lot of them if you just Google up the generic term resinous flooring.
Fantastic. Thanks very much. We are out of time for today, so thanks very much again, Darcy and Sam, for this interesting and thoughtful look into what differences occurred and steps taken and energy expenditure among acute care nurses when their work environment moved from a hospital with centralized nurse stations to a hospital with decentralized nurses stations. This concludes our event. We'll also leave the webinar open for another 30 minutes or so that you can download the EDAC and AIA CEU forms. Thanks again, everyone, for joining us, and have a great day.